Today, Dr. Janmejay from GCS Medical College is the presenter. And I can see the new postgraduates on the screen. That is a good thing. I welcome all of you. And please keep your video on and interact very freely whenever we are discussing. And even those who are on the attendees link, they can also put their questions, queries on the chat box, and we'll incorporate in the discussion. With this remark, I request Dr. Janmejay to share his PPT and start the history.
Being a mother, uh, uh, a 1 month 25 days old male child, Hindu by religion, residing at Ahmedabad, belonging to upper lower socioeconomic class as per modified Kupuswamy scale, living in Pakka house, presented with complaint of a large head, and baby had antenatal history of conceived naturally after 1.5 years of active married life, regular antenatal visits taken at 4, 6, 8, 9 months. 4 antenatal scans were done. USC at 9 months showed large fetal head according to mother, but no documents available. Natal history: baby was delivered at full term by LSES due to large head. Baby cried immediately after birth and having birth weight of 1.8 kilogram. After birth, history of NICU admission for 3 days for low birth weight. After birth, baby had progressively increase in head size and with no history of seizure. Baby able to move or fold limbs spontaneously, cried vigorously, and accept feed well. Baby passes urine and stool normally. Baby had no history of fever, no history of vomiting, no history of trauma, no history of hemolytic disease, and no history of jaundice.
Okay, can you just stop for a while? I think, Janmejay, I understand that in this type of the case, you have some point that how to start the presentation, right? So you did it very rightly, but I think first slide should be with the complaints, right? And that you can say that this has been noted since even the antenatal period. I would like to start the history from the antenatal history, right? But the first slide should be for whatever the problem the child is brought to you, that you should mention in the first slide. Anyway, good. I think let us start. We'll come to our case later on. But here what Janmejay mentioned, that the main chief complaint of the child is the large head. And let us discuss the large head, the broad, I will say, thoughts, not pertaining to our case, that 1 month and 25 days, of any even the older child. And that's why I will say that first, what is the large head? What we mean by the large head? You know, somebody will ask in this way. Anybody? I think some of the questions which I'm asking or discussing may not be related to the, I think, post-graduation. It is very basic, even to the undergraduate. So everybody can participate. You know, mother will complain of the large head. You are sitting in the OPD. So first, how will you decide that the large head is there? I think before we start this discussion, let me welcome Dr. Srinivasan sir. Just now he joined. Sir, welcome. And one more faculty is there with us, Dr. Deepa Firke. She is also professor of pediatrics from Miraj Medical College, Maharashtra. And I request both these faculty that please, whenever you feel, you make the comments, your questions, so that we can learn from each other. So who will take the first question? Mother complains of large head. Child is brought to you in the OPD. How will you decide that it is large head? Janmejay, let me start from you. Then I think gradually others will join. Janmejay, you are muted. Unmute yourself. Or anybody can take. Janmejay, you are muted. Arjun, you can take it.
Sir,
Okay, Janmejay. Okay, Janmejay started.
after birth, baby's head circumference we measured, and if baby's head
As I said, suppose 5 years old child or 2 years old child is brought to you, 2 years old child is brought to you with a complaint of large head in the OPD. Now, how will you decide that really this is large head? Then probably you will go for the further thoughts.
Sir, growth chart plotting at that age, and if head circumference falls beyond plus 2 SD, 2 standard deviation.
Somebody is putting on the chat box. I request that if I come to know, I can acknowledge. So very rightly that, you know, sometimes apparently it may be, then probably it may not require the confirmation. But still, best way, yes, Abhishek. Abhishek, you can rename yourself. Rather than doctor, you can rename yourself. Dr. Abhishek Agrawal. Yes, good. So very rightly he said that we can measure the head circumference and then put on the growth chart and see for that age. If it is more than 2 standard deviation, or even the more than the 98th, 97th percentile, right? We say that it is the large head. But the first question comes that how will you measure the head circumference? Very basic question. I think any person can answer. Dr. Charana, I think in MBBS you must have been taught that how to measure the head circumference. So I'm asking that there is a
Yes,
basic question and somebody is going to ask you in the MD examination. Please.
hello.
Yes. You are audible.
Sir, the head circumference is measured between the two protuberances. One is occipital eminence and one is frontal eminence.
Okay.
We take the measuring tape and we wrap it around both the eminences.
I think you know that we have to put very appropriate anatomical landmarks, right? And what are the anatomical, what is the another name of the head circumference? What the neurologists commonly say, they don't say head circumference. Anybody? Arjun, any idea? What another name?
Occipitofrontal circumference.
Absolutely, Monica. Occipitofrontal. So which is the point in the occiput and which anatomical point is selected in the frontal region. And if you measure the circumference of these 2 points, that becomes the size of the head. That's why I said that the answer should be so precise that examiner should not get the chance to ask you the next question. I think Jarna tried, it's fairly good, but we want very precise. Janmejay. Sometimes the same thing happens in the MD examination. If they ask the so basics, then we are in trouble because we have prepared so much complicated, but they are asking the basics. Yes, anybody? Arjun? Arjun, you are muted. Unmute yourself.
Sorry, sir. Sir, question.
For occipitofrontal circumference, head circumference, what are the anatomical landmarks where you select one point in the occiput and second point in the frontal region? We want to make all the basics so clear, so probably we should not find the difficulty.
Sir, supraorbital ridges.
Yes, one person. Janmejay.
So one landmark is occipital protuberance, and the anterior landmark is supraorbital ridge.
Okay. I think still one more adjective to the occipital protuberance. You are right. But to be very precise, one more adjective is there for very, I will say, precise location. Priksha said superior occipital. Priksha, then it will be called as the Priksha's occipital protuberance. Priksha. Anyway, but she tried. You know, if I remind you whether the occipital protuberance is one or two types. One is external, another is internal occipital protuberance. And therefore here we say external occipital protuberance to frontal ridge. Charna, in the frontal region, right, rather than the prominence in the frontal, it is the frontal ridge, this orbital ridge. Right, this is the head circumference. One more question. Which type of the measure tape should be used to measure the head circumference? Is there any specific measure tape or the same one which the tailor is using of the plastic? Can we use it? Yes. Janmejay, I think there is some problem. Your voice is not clear.
Sir, non-stretchable.
Yeah. But what is the material from which it is made? Non-stretchable, you are right. But any specific material, do you know? As I said, plastic. The tailors, they are using the plastic measure tape. And here we say that it is a stretchable. So best way is to avoid it, non-stretchable. And then what is the non-stretchable material? I think all the things are given in this clinical examination. And people are asking this basic question just to check it, whether in the MD, whether you are aware of it or not. You know, it's a fiberglass material. This non-stretchable measure tape is made up from fiberglass material. And that measure tape should be used. Then the next question may come, I think, with the head circumference, because very basic questions I'm discussing with you. I think some seniors may feel that we are taking time for these basics, but I think worth to spend. What is the rate of increase of the head circumference? Because it's very important in pediatric practice. Every pediatrician should know what is the rate of increase of the head circumference at different ages. Anybody will say? Whatever you have the idea? Because you know that the head circumference is very important because it is concerned with the growth of the brain. And all of you know that the growth of the brain is maximum in the first 2 years. Right, starting from intrauterine life to first 2 years are very important. Brain is growing. And therefore, rate of growth is very important for us to know in our daily practice. And for that reason, I think we should know just measuring is not sufficient. After measuring the head circumference, I should be able to decide that for this age, is it right or wrong? And suppose if you have the serial head circumferences, then you should even see what is the rate of increase, that velocity, right? And that velocity is also right or not. If it is not right from early, you can suspect that the head is not growing properly due to some reason. And that's why I think this question is very important. Who will take it?
Sir, in first 3 months, 2 centimeter per month.
Very good.
And then 3 into 6 months, 1 centimeter per month.
Hmm.
And then 0.5 centimeter per month up to 1 year.
Okay, beyond that? Because you know, first 2 years, yes, but even head, slowly then it slows down the growth, but maybe even at what age the adult size reaches? Adult size of the head, at what age it will reach?
5 to 6 years.
Absolutely, usually 5 to 6 years. And therefore that time is very crucial for the pediatrician. So up to that, you should try to follow that how the head is growing. Very rightly Arjun said, please remember, first 3 months, the rate of increase in the size of the head circumference is 2 centimeter per month. Then 3 to 6 months, 1 centimeter per month. And from 6 to 12 months or 1 year, 0.5 centimeter per month. And 1 to 3 years, they say that 1 centimeter per 6 months. That means almost 2 centimeter in a year. And later on, probably 1 centimeter per year. And up to 5 to 6 years, it may slowly increase and may reach to the adult size. So I think this basic concept is very important for all of us. And I'm taking so precisely because some of the new residents have joined, junior residents. Sir, Srinivasan sir, yes, I was waiting for your comment.
No, I came a bit late because I was in academic course
Yeah.
on hematology. Just it was over.
Yeah.
So sorry for the delay. Okay. So what I am wanting to tell, just
Sir,
to
yes.
allow me to tell. So usually I this thing, all undergraduates and postgraduates, and they enter both in JIPMER and Mahatma Gandhi Medical College. I ask them, so you know your height, you know your weight, they will say yes. I'll ask, do you know head circumference? They will not know. Okay. So I said, each one of you, one boy will take the head circumference of the other boy, and similarly a girl will be taking, because my brain nobody bothers how this thing. Yeah, so I was reminded of that. So that is the exercise I usually give.
Thank you,
Okay,
sir.
so
Thank
that they
you.
should. I just asked them whether they know what is the head circumference.
Yes.
How,
So I think this is a question to
Yeah.
Head, Jyoti, Jarna, Nirali, or all the students. What sir is
so what
asking.
is that? How much? 45 centimeters, 55 centimeters, 65 centimeters.
Yes, sir. And it happens that we may not be able to answer. Yes, and sir ने बोला ऐसे कि you will be able to answer for your weight, but may not be knowing even other parameters for our own self.
Of course, everybody will know about chest circumference because for recruitment to NCC and all, they used to take inspiration, expiration. And
Sir,
of course,
you are known to all of us and our old residents, but for the sake of our new residents, I would like to speak few words for Srinivasan sir. Dr. Srinivasan sir is a very senior teacher of this country. I will say country. He is retired professor and director from JIPMER, Pondicherry. And even he must be, I think, 75 plus plus still sir is attending every academic.
Yeah, 77 November I am
Oh,
becoming 78.
77. And he's very keen, rather than, I will say, junior residents are keen to know and to discuss. And we are fortunate that we are getting his benefits in our Tuesday PG Clinic from, I will say, the day we started. And Dr. Deepa Firke, she is also, I would say, very good academician and teacher from Miraj Medical College, Maharashtra. I'm sure that Madam will also in between give some comments, and definitely will be getting the benefits. So I think
One small correction, sir. I am attending as a learner like you. Okay. Because there's so much to learn from Dr. Prajapati. Okay. Yes,
Yes,
not
sir, I
as a
totally
teacher.
agree.
Yes.
So actually, what was my point? That we should know all this, and I am sure, Janvijay, somebody will start from these points in the examination, just to verify whether we are aware all these things or not, and therefore how to measure, what is the rate of increase, and then how you are plotting on the growth chart, how you are deciding large head, and then the question comes of large head or small head, and then probably you will give the various thoughts and regions in the history and examination and try to locate the cause. So I think that was my idea, that always best ways to think in this direction. Now, suppose you decided the large head. Yes, it is large. You have plotted on the growth chart. Then the next question comes, what are the various reasons for the large head? I don't want the causes, but various regions, factors, pathologies responsible for the large head. That means which is responsible for making the head size larger. What are the various factors or mechanisms? Then we'll come to the causes. So I think if we go with this one by one step, it becomes easy for us to understand. Who will take it?
Sir, it may be a familial.
Okay, I think Arjun is speaking. Yes, Arjun, please.
Sir, one of cause is familial.
I
large
think,
head.
let me, sorry, Arjun, he spoke the very first point, is very, very important. Don't jump for the pathology.
Yes, sir.
Sometimes mother may be complaining, and therefore here it is very important that you should measure the head circumference of the parents also, or even some relatives. And suppose in the family, apparently without any pathology, maybe the familial. And suppose familial, a normal child, no any neurological problem, no any other findings on examination, probably that baby does not require any workup. Don't go unnecessarily MRI or some other, even I will say investigations. So very, very important point, I think Arjun addressed very rightly. So give the first thought. Is it really familial? Look at the mother, look at the father, or even some relatives, even you can measure and see, right? That is a very important. Okay, suppose if it is not familiar, Arjun, then what are the other reasons?
Sir, it may be due to fluid collection like blood or something
Another
else.
point, very good. Most common cause for us, that means collection of fluid, hydrocephalus, what we say. But hydrocephalus can be the various regions. We'll go for the regions causes later on. But we'll try to give the thought that if it may be the familiar, maybe due to hydrocephalus, further, Arjun.
Sir, it may be due to a thickened skull like anemia
Okay.
or something else.
In an older child, you know that hemolytic anemia, very well known to us, is the thalassemia. The thalassemic child, if you see, look at the head, there has the multiple, I will say, abnormality with the head. Size may be larger, frontal bossing may be there, right? So many things will be there. So that can also be there. Anything else?
Space occupied lesion in brain parenchyma.
Okay. Yeah, that again may be probably responsible for hydrocephalus. Any vitamin deficiency?
Yes, sir, rickets.
Yeah, rickets can also cause. You must be knowing. Anything else further? Suppose child is short, apparently short looking child, but head is large. It's a short child, short stature, I will say.
Achondroplasia.
Achondroplasia, very good. Achondroplasia. So the achondroplasia can have the large head. Any other? Any other similar common conditions, I will say daily the practice what we may come across? Anybody? Even in the MPS, mucopolysaccharidosis, if you have seen, their head is larger, right? Even sometimes due to the other regions, like subdural hematoma, right? Or due to any collection of following the trauma or bacterial meningitis, suppose subdural hematoma, empyema, that can also give rise to the head. But another terminology, what we are discussing, large head, is another name with the macrocephaly. Macro means small, macro means larger. It's a macrocephaly. But another terminology, the megalencephaly. Megalencephaly and macrocephaly are same but different. Somebody is speaking. Please, can you mute yourself? Please mute yourself. Somebody is talking, please. Shweta, I think DIP person, can you mute the person who is talking, please? Shweta. Okay, is there any difference in the macrocephaly and megalencephaly, or both are same? Who will take this point? Anybody? I'm sure that you must have heard this terminology, that macrocephaly, which we are discussing, large head, and one other terminology is megalencephaly. Whether megalencephaly and macrocephaly both are same or different? Anybody?
Sir, megalencephaly is the increase in brain weight or size. And macrocephaly is a increase in head circumference. It can be anything, brain or CSF or.
Yeah. Sagrika has entered, and very rightly she said that macrocephaly, that means just size is large, but megalencephaly, that means brain tissues are more, and that can be due to several other reasons. Megalencephaly, what we say, megalencephaly, that means the brain tissues are more. That can be due to the white matter region, gray matter region, various conditions. Can you give an example where the megalencephaly is there so that you can remember?
Sir, cerebellar gigantism,
Okay.
Soto syndrome.
Right. Any other white matter disorder, Sagrika? Where the head is larger, and megalencephaly even. If you see the brain tissues are more. If you heard these white matter degenerative disorders.
Sir,
yes, anybody?
Sturge-Weber and.
Yeah, Sturge-Weber, they are the neurocutaneous.
Yes.
I'm asking the white matter degenerative disorders. You must have heard the Alexanderson disease and Kenevan. Alexander and Kenevan, they are the white matter disorders, and they usually have this size of the head is large, and for that reason, there is the megalencephaly. So I think megalencephaly and macrocephaly are different. Yes, megalencephaly is the part of the macrocephaly. That means as a cause for the macrocephaly, that can be the megalencephaly. And megalencephaly can be due to the white matter or gray matter problem. So I think this is the thing that how we can remember. This is the only thing which we have considered the large head. I think Dr. Mita is there. Mita? Because Mita, I wanted to confirm, Dr. Naresh Biyani, our neurosurgeon, was going to join with us. So I think, Mita, you can confirm with sir, and he can join later on after some time. But I think later on we can come to this point of the discussion, then at least you can confirm with presence. Okay, Janmeja, I think now you can go further. Yes, yes.
Sir, good evening. I'm listening to all the things.
Oh, sorry. I could not locate you.
No
yes,
problem.
I wanted to acknowledge you.
Yes, sir. Yes,
We
I
are
am there.
fortunate to have the Dr. Naresh Bihani. He is a pediatric neurosurgeon. Not, I will say just neurosurgeon, but pediatric neurosurgeon. And I'm sure that we learn many things from him, particularly the surgical aspect and even the general all these points. Sir, Naresh bhai, we will wait for some time.
Yes, yes, sir. I'm
We'll
mute
to
and
your
I'm
point.
listening to the
And,
conversation.
and still, even you can also contribute in our discussion. I know that sometimes you'll be more clear on all these discussion. But I think basic is required for our pediatrician and for our postgraduates. That's why
Yes, sir, yes,
probably it will
I'll
be
do
very
that.
superficial for you, but we are going like that.
Yes, I'll be.
Yeah. Okay. I think Janmejay, you can now, before you go, Janmejay noted that the larger head was noted even during antenatal visit in the sonography. And that was at the 9 months, right? So Janmejay, before that also sonography were done multiple times. They have not noted this larger head before that, or only at full term they noted it?
Sir, in third trimester, they have noted the large head in antenatal scan.
Whether it was informed by the parents or you check these reports?
Sir, informed by the parents.
Okay, so I think parents may not be knowing. The point, that is also another thing, that when it was noted, that also gives some idea that what is the likely cause or what can be the problem or what type of insult is possible. Anyway, now I think we can go further in this history part. I think you can take the negative history. Probably we are not paid the attention.
Baby had no history of fever, no history of vomiting, no history of trauma, no history of hemolytic disease, and no history of jaundice.
I think just for a minute, please stop sharing. The negative history also he has mentioned, and Janmejay, can you give the reasoning for mentioning this particular point? Suppose no history of fever. Janmejay, you are muted. Unmute yourself.
Sir, if whether any infective focus or new any sir, cancer like lesion in head or any
Suppose what you want to convey from the presence of fever with the related to large head. Suppose if you are discussing large head, and with that no history of fever, in what way it is related, how it is relevant?
Sir, if any tuberculous mass
In a 1.5 months old child, you are discussing, I will say, tuberculosis. Our patient, you said, I think 1 month and 25 days. That is almost 2 months, right? It's only 2 months old child. Are you suspecting tuberculoma or CNS tuberculosis in this patient? We'll have to put the relevant. Anybody can have any comment? Suppose the point of fever. How will you put it in this patient which we are discussing? Because already he said that this sonographically antenatal, even they detected this large head and probably hydrocephalus. Then in what way this fever is related? Please always find out the explanation, whatever we have mentioned. Sagrika, what is your idea?
Sir, CNS infection like meningitis, encephalitis.
Yeah. But here, this problem was before the delivery. So are you thinking of intrauterine problem?
Yes, a torch infection.
That's why and then fever to whom? Whether the baby or the mother?
Mother.
Yeah. So if at all fever, I would like to ask whether the mother was having the fever during pregnancy. That means any point indicating some intrauterine infection, and therefore history of fever, history of rash to the mother during pregnancy. Probably that may give you the idea that, okay, this is possible, some intrauterine infection, and which has manifested in the form of the large hair or hydrocephalus. So be the very precise, whatever you mention the point. Okay, what are the second point? Vomiting. Janmejay.
Sir, in any space occupying lesion, common
Janmejay, again, what space occupying lesion in 2 months old child is going to develop? You suspect this space occupying lesion in 2 months old child. But yes, vomiting can be due to some other reason in a case of hydrocephalus.
intracranial pressures.
Yeah, raised intracranial pressure. Usually in these babies, AF is open, may not be on the vomiting in spite of the raised pressure. But suppose raised pressure is so much, it may happen so that may present with the signs of raised intracranial pressure. Trauma. Which trauma? Because this is the finding during pregnancy, antenatal period. But any problem during antenatal period can cause the hydrocephalus. One is the infection. Anything else? Any idea, Sagrika? Suppose
Sir, hemolytic disease of fetus.
which hemolytic will cause this?
ABO incompatibility.
But will it cause the large hydrocephalus? On the contrary, keep in mind, even acute hemolytic condition will never cause the changes because it requires long time. In thalassemia also, if you see, initially there are no changes. But the very chronic hemolytic anemia, then it may result in the change in the head size and shape and all the problems. Skeletal changes, right? But suppose intrauterine hemorrhage even, that is possible, and which can result in a case of even the hydrocephalus. Hemolytic disease again, probably acute should not cause. Jaundice again may be the part of it. I think here let us take the opinion of Naresh Bhai. Dr. Naresh, can you just guide us that suppose intrauterine hydrocephalus is detected, then what various reasons we can keep in mind? Except even the congenital. Yes, congenital reason is very strong. But related to all these negative points, what he had mentioned, please.
Correct. So when antenatal scan is done, most of the people, they look for the dilated ventricles. Okay, sir. So sometimes you can have an ex vacuo dilatation of ventricle, something like a torch group of infection, without causing hydrocephalus or increase in head circumference or biparietal diameter. So whenever we see an antenatal diagnosed dilated ventricle or ventriculomegaly, the next thing that we would like to see is the biparietal diameter appropriate to the gestation, number one, and also the head circumference appropriate to the gestation. So that can easily rule out whether it is a real hydrocephalus or ventriculomegaly related to ex vacuo dilatation of the ventricle because of the brain injury. And toxoplasmosis is the most commonest of it.
I think you have brought a very good point there. Can you make it more clear that what it is just ventriculomegaly?
Yes. So ventriculomegaly, antenatally, the definition would be like dilatation, the diameter of ventricle, lateral ventricles at the level of atrium is 10 millimeter. Any any uh, anything that is more than that is taken to be ventriculomegaly. Okay, sir. Just having ventriculomegaly doesn't mean that the child has hydrocephalus. When we talk about hydrocephalus, that should have also the signs of raised ICT.
Yeah.
What are the signs of raised ICT would be? Antenatally, it's the dilatation of the head circumference more than the regular gestational age, or bipetal diameter that is more than the gestational age.
I think Sir has made the very important point. Please remember what he said there, the antenatally, if you see on the sonography scan, just dilatation of the ventricular system, not necessarily it is hydrocephalus. What he said that there may be certain conditions, and like the torch infection, where due
Yes.
to infection itself, brain tissues are not growing. And because brain is not growing, fluid is more accumulated. And therefore, apparently looking this dilated ventricular system. But if you look at the size of the head, or even later on, even the symptoms and signs of raised intracranial pressure, they are absent. So that means it is not the hydrocephalus. It is the dilated ventricular system because brain tissues are not growing. And I think later on, again, we'll come to Dr. Naresh Bhai that what exactly the definition of hydrocephalus. Dilatation of ventricular system plus signs of the raised intracranial pressure, and if one the apparently height may be larger in size. So I think that is also very important that just from the ventricular system dilated on USG scan antenatally, we cannot decide that it is hydrocephalus. It can be just dilated ventricular system because brain tissues are not growing. So that is also very, very important point. And that he mentioned that with this, all the other measurements, size of the head, even antenatal also it can be done. And plot on the growth chart with even the gestational age and see whether it is large or appropriate and decide. So I think this is also very, very important point. Okay, Janmeji, can you go for further with the history part?
Child had received only birth vaccine, BCG and OPV. The child had no history of familial macrocephaly, no family history of neurocutaneous syndromes, no family history of bleeding disorder, and child had started breastfeeding on first day of life, and history of bottle feeding is present. Currently, child is on partial breastfeeding. On general examination, child is awake, crying, which was high pitched, looking. This is an IUGR baby, and anterior fontanelle and posterior fontanelle wide open, bulging, dilated veins appears on scalp. Capillary refilling time is less than 3 seconds. No other congenital anomaly present. On anthropometry, child had weight of 3.5 kilogram, length is 55 centimeter, head circumference is 49.5 centimeter, and chest circumference is 30 centimeter. On systemic examination, child is awake, crying, both eyes downwardly placed, upper sclera visible, sunset sign present, bilateral pupils normally constricted and reactive to light, transillumination test positive, McEwan signs positive, tone is normal in all 4 limbs, deep tendon reflex is mildly exaggerated, and plantar reflex is extensor with no spinal deformity. These are the pictures of patient.
Can you show that what you want to show over here?
Sir, anterior frontally large, open and bulged with dilated veins visible
I
on
think
scalp.
very apparently quite obvious dilated veins are seen. So please remember to all the students, this is on the contrary very bad for the child, that very large hydrocephalus. So signs are obvious, but not good for the patient. Anyway, what else is seen over here?
Sir, upper sclera visible with sunset sign.
Okay.
Sir, lateral divisions of eye, which occasionally present.
So what does it indicate?
Sir, sixth now, due to along its course, if pressurized, then palsy of 6 now can be happen.
Okay.
Sir, low birth weight baby, sir.
Okay, go ahead.
Other system examination per abdomen is soft, non-distended, no organomegaly. On respiratory system examination, on auscultation, bilateral air entry equal with no adventitious sounds. On cardiovascular system examination, S1, S2 is normal, no murmur present.
Okay, can you stop sharing? I think other students, any comment from you or question to Dr. Janmechai? What probably you have noted something which is not appropriate or which is not right? Anybody? Sagrika, any point from your side?
Sir, vitals.
Yeah, vitals. Janmechai, have you mentioned? What is the temperature, pulse, respiration? Even you should check the blood pressure also. 1 2 months old child. I think it is missed, not seen. Is it?
Yes, sir.
Okay. What can happen to the pulse rate, Sagrika? He has not mentioned, but many times what can be with the pulse rate or heart
Sir,
rate? This may be.
sir, in a raised ICP patient, there is a Cushing triad. It is hypertension, bradycardia, and altered respiration.
Okay, maybe bradycardia. Bradycardia is due to what in these patients? What is the mechanism that means? How the bradycardia develops in a case of hydrocephalus due to the raised intracranial pressure? Yes, Monica, Mita, silently listening or silently watching? What is the mechanism or explanation for a bradycardia in a case of raised intracranial pressure? Anybody? I think it is quite well known. Arjun, any idea? No, to raise the which particular nerve may cause the bradycardia?
Vagal now, sir.
Vagus nerve. Vagus nerve stimulation can cause this bradycardia. Why there is the possibility of vagus nerve stimulation in a raised intracranial pressure? If you know that, you know how the vagus nerve name is derived. What do you mean by the vagus? Vagan. Any idea, Jyoti? You must have heard the vegan. Some vegan boy. What we mean by it? That means wandering, not working and just wandering boy. That's why we say vacant boy. And here the name vagus name is derived from this. It's a very long now and wandering. And due to this long pathway, due to raised intracranial pressure, there is a stretching of the vagus nerve. And stretching of the vagus nerve causes the stimulation of the vagus, which is responsible for bradycardia. And hypertension, what even Sagrika said, sometimes in older children you may get due to the autonomic system activity. Respiration may be due to the even displacement of this respiratory or the pressure effect over the respiratory centers. But I think when the anterior frontal is open, these findings are not common because it is getting the space, because anterior frontal is open, posterior frontal is open. Therefore, as the pressure increases, head is enlarging, but less of the pressure effect over this. Signs of pressure effect may be less. If it is close, directly they may present with all the signs. Anything is missing in his presentation? Very important point, particularly for the exam and even I would say practice also. In the past also we have discussed several times, but somehow repeatedly we are missing. Growth chart is not there. Janmeja. Am I right? I think, and you know, somebody has put it very rightly that anthropometric sometimes head circumference, you know, if you have gone for the growth chart, you can show exactly that where the head circumference is falling. So growth chart is very important, and even how the child is growing from the weight point of view, height point of view, length point of view. So any condition, even normal child, growth chart is very important, and here probably more important. He has mentioned and shown even in the picture that is a sun setting sign. What is it? Sagrika, what is sun setting sign and how it develops in a case of hydrocephalus? What is the mechanism or explanation?
Sir, sunset sign is a downward placement of eyeball, and upper part of the eye is visible more. It is due to raised ICP, and because there is a continuation of meningeal sheath with brain, so CSF will stretch the optic nerve fibers, and there is downward displacement.
Okay. Anybody else? Anybody else have some other idea? I'm sure in suppose a case of hydrocephalus, if you get, and you know it is very common in the MD examination. And I'm sure that some examiner is going to ask you this question. Somebody has put the supranuclear upward gaze palsy. Yes. But why it happens so? You know, basically child is not able to rotate the eyeball upward because upward gaze is lost. Palsy of this upward gaze is there.
Pressure on which area?
Yes,
Pressure
sir.
on which area? I was asking, no?
Yeah.
Pressure exerted on which area of the?
Which area? As exactly sir says. You know, if that area is affected, that is the loss of the upward gaze. That means where is the center for this upward gaze? Anybody is able to recollect the anatomy? At least somebody has put very
As an
rightly.
intern examiner, I will give you a clue. TTM
Yeah.
of MB. TTM of MB.
Yes, very rightly somebody put dilated supra. It's a, you know, it's a suprapineal recess. Suprapineal recess, which is getting dilated, and suprapineal recess constantly causes the pressure over the which center, which area, which is that center for the upward gaze, and which is lost in a case of hydrocephalus. And therefore, sun setting sign or sunset sign is seen. Area of
Term of midbrain.
yes, midbrain. Which area? Yes, somebody has put on the chat box. Yes, it's a tectum. And this area is constantly pressed by the suprapineal recess due to the collection of CSF. Suprapineal recess normally anatomically also it contains the CSF. In a case of hydrocephalus, it getting more CSF and getting the dilated, and it causes a constant pressure over the center, and therefore upward gaze is lost or upward gaze palsy develops. Therefore, child is not able to uplift these eyeballs, and therefore it is downward displaced, which is giving the classical appearance of sun setting sign. I think very important, at least for us to remember that how it develops. So please remember. Another point which probably he has discussed, or one more sign for the hydrocephalus he has seen. Is it right or you have some point? Anybody? I hope that others are listening and noting these points. He has mentioned, if you have not noted, I will draw your attention. He has mentioned the Meseval sign is present. Any comment from anybody?
Sir, McEwan sign is present after the closure of fontanelle.
Yeah. So child is only 2 months old child. And in a 2 months old child, these fontanelles are going to be open. And in an open fontanelle, the sign is not having importance because normally also it's a crackpot sign. In other way, what we say. That means if you try to percuss it, it gives this sound very classically as if the pot is cracked. And that even with the stethoscope on one side, you can put the stethoscope, opposite side, you can even just struck or percuss, and you can see this sound as if the pot is cracked. That is the Meseval sign. But it's important after the closing of the center fontanelle, and that is after the age of 2 years. Right, so this point we cannot consider as positive for our sign of the hydrocephalus in this patient. But up to what age you can use this Meseval sign? Any idea, Sagrika? From 2 years to what age? Suppose some adult is there, 30, 40 years old person. Are you going to get the Meseval sign? That is the next question. So please remember, I think if anybody is knowing, please, you can give the comment. We said after 2 years, because before 2 years, fontanelle is otherwise open. It is from 2 years to 18 years. 18 years, why? No, up to 18 years, the sutures are closed, but they are not ossified. And therefore, if some pressure increases, they are openable. And if these sutures are openable, you can get this crackpot sign or Meseval sign. But after the age of 18 years, they are totally ossified and therefore not openable in spite of raised pressure. And therefore, you will not get the Meseval sign positive in spite of even the raised intracranial pressure. So the Meseval sign will be present from 2 to 18 years. And why from this age, that we should draw. Skull simulation test is good. I think somebody is going to ask you the demonstration. If you can demonstrate, it is very good. But I think in the examination, what I wanted your attention, that whenever you go for demonstration or some science and all the things, you should know all the points. That what happens to the vitals, head circumference and everything should be plotted on the growth chart. Once we are focusing hydrocephalus, we'll have to go for all the demonstration of all the signs. Positive signs, you'll have to note it. Try to find the explanation, and suppose the absent, then also you should know. I think here what Janmejay was trying to show, the 6th nerve palsy. What is the reason for the 6th nerve palsy? Suppose the pathology is there. How you can explain? In the absence of other CNS findings. You know, 6th nerve palsy, that is lateral rectus is paralyzed, and therefore eyeball is pulled inside. The child cannot move on the laterally. That is the 6th nerve palsy. And that many a times, even in the absence of other CNS findings, it can be. In several CNS conditions, it can be. And that is the false localizing sign. That may be due to the raised intracranial pressure. Again. So I think all these points, whenever you have, he has mentioned, suppose in this patient, he has said that it is normal, but in older children, sometimes there may be the hypertonia, hyperreflexia, extensor plantar. Why it can be? In a case of hydrocephalus, you may get these positive findings. That is, hypertonia is there, depth and reflexes are exaggerated, plantar is extensor. How will you explain in a case of hydrocephalus? Anybody? Suppose older child is there, 2, 3 years, 4 years, you may get these signs. Anybody? You know, this pyramidal tract fibers irritation. In a case of raised intracranial pressure, the pyramidal tract fibers are actually sensitized due to the stretching effect. And therefore, you may get this upper motor neuron type of lesion. Spasticity, hyperreflexia, plantar extensor. Even sometimes it can cause the neck stiffness also, even in the absence of infection. So all the points I think we should know in the examination, and somebody is going to ask. I think before we go, we'll take the help of Dr. Naresh Vai for this clinical examination. Then we'll go further, I think, and then his role is very important for us to understand for diagnosis and further. Dr. Naresh Vai, any examination points which probably we have missed, or anything which you want to make the comment?
No, sir. No. Only the thing was that 6th nerve palsy happens because of the 6th nerve that arises from the brainstem, and it has a long course L along the posterior fossa, middle cranial fossa, reaching up to the orbit, anterior skull base. So because it has a long course and it's very thin, this is the first nerve that gets susceptible to the raised ICT, sir.
Yeah.
And
So
that is why 6th nerve palsy happens.
Yes. Sir said, I think a good explanation for the 6th nerve palsy, which we can keep in mind.
Yes.
Okay.
That's the only thing that I want to add.
Yes. Thank you very much. I think now we can go for the investigations, and now Naresh Bhai, you can focus from the radio imaging and can guide us that how best we can do for this one diagnosis and further management.
Yes, sir, I will do that.
You can share this PPT.
Yes.
Investigation at NCCT at 1 month and 21st day of life. Markedly dilated lateral and third ventricle. Right ventricular size is 5 mm and left ventricular size is 7 mm, in which more than 2 mm is significant. Possibility of aqueductal stenosis and marked atrophy with cerebral parenchyma, possibility of hydrocephalus. In routine examination, hemoglobin is 9.1
I
gram
think
per
Dharmendra, you
deciliter.
can go for the interpretation. Is there any significant abnormality of any routine investigations? Otherwise, you can go further. You can make
No,
the
sir.
comment rather than reading these point figures. You can make this interpretation.
Sir, all routine examination is normal, sir.
All the investigations were normal.
Yes, sir.
Okay. I hope that you are right.
On CSF examination, culture was negative. No any organisms were isolated.
But what was this routine? There must be the CSF, protein, glucose, cells.
Sir, routine microscopic details were not available, sir.
Oh, it's not available because already CSF is done. That is the first, I will say, information coming to us. Anyway, here also I think it is also important. Anyway, Dr. Naresh will explain us that what is the importance of CSF examination. Anyway, whatever you have done, just show it, then we'll come to the discussion.
Sir, NCCT scan of the patient.
Anyway, I think Naresh, you can explain us this. Probably we may not be expert to interpreting.
No. It is let him do that, sir. What we are seeing right now is a non-contrast CT scan. Okay,
Yeah.
and hello, can you see?
Sir.
Hear me? Yeah. So if you can go the images little bit downer, So we have just one image actually. So whenever we see hydrocephalus from an imaging point of view, we have to rule out that there are three things actually. One is like, if somebody can mute yourself,
Yeah, because I think that's why the sound.
Echo is happening. Yeah. So one is the dilated ventricle. Number
Yes, Naresh, go ahead.
I'm sorry. If all the four ventricles are dilated, then it means that it's a communicating hydrocephalus. And if the fourth ventricle is small and the third ventricle and lateral ventricle are dilated, it means that it's a triventricular pattern of hydrocephalus, and there can be an aqueductal stenosis, like what we are seeing in this particular case. And also because of the chronic long-standing hydrocephalus, probably what we are seeing is the brain matter is severely compressed.
You have any other picture? Chanmay?
No, I have seen the go down. This is the vertex thing.
Okay. You have anything else, Chanmay, to share?
No, in presentation there were only two pictures.
Chanmay, unmute yourself. Chanmay, you are muted.
Yes, sir.
Anything else you have to share?
Sir, full digital scan is available, sir.
Okay. Then you can just stop sharing. I think we'll try to learn more details from Naresh bhai. You can just stop sharing. Naresh bhai, I think we are general pediatricians,
Yes,
including our postgraduates and myself. So
correct.
we want to learn more from you, details of it, that even you can take some basics of these CSF circulation. Then I think the hydrocephalus, that how we can define it. Then the various types of the hydrocephalus, where common conditions we are coming, I will say, in the practice. Then probably you can go for the management of shunt and everything. But you can take, I will say, these basics for us.
Correct, sir. So now this case, what we would have done first is that if there is a dilated ventricle, if the large head with a sunsetting sign, the first screening test that we would do clinically is an ultrasound. Okay. Why would we do an ultrasound is that it is a bedside and it is non-invasive and it is cheap and it is a sensitive tool. So first we need to make sure that we are really seeing a hydrocephalus, number one. And once the hydrocephalus is uh, diagnosed on an ultrasound, then neuroimaging is asked for. Neuroimaging consists of two things. One is a CT scan and another is an MRI. In a growing brain, we don't recommend an CT scan unless it's an emergency. Okay, sir. Because CT scan has a ionizing radiation among themselves. Suppose we get a child, like this child was 2 months old, so MRI is preferable. And now the MRI is easily available at all the centers actually. So previously, like 5 years, 10 years down the line, MRI was very precious and people couldn't get it. But now almost all the medical colleges and district hospital, they have an MRI. And MRI would give us more of the anatomy and also the cause of hydrocephalus. Now going back to the causes of hydrocephalus, first we have to differentiate is that the child is born with large head or the child is born with a normal head circumference and then started raising the head circumference. So any child that is born with large head, that is a congenital hydrocephalus, and then you have a congenital causes of that. The most commonest that we know is the primary hydrocephalus. Secondary is because of the another congenital malformation like Dandy-Walker malformation or meningomyelocele. Actually, 30% of the meningomyelocele neurotube defect presents with hydrocephalus, dilated ventricles. And recently, with the better neonatal care and all those stuff, what we are seeing is in a corporate hospital, the most commonest cause of hydrocephalus now we are seeing is a prematurity related IVH, intraventricular hemorrhage related to the sequelae and then leading to hydrocephalus. If you want to understand the circulation of why in post IVH the hydrocephalus happens is that when we have 4 ventricles, 2 lateral ventricles, 1 third ventricle, and then 4th ventricle. And lateral ventricles are communicated with third ventricle with foramen of Monro. And third and 4th ventricle is communicated with aqueductus, Stilwell's aqueduct. So when there is an intraventricular bleed or any infection, it causes inflammation and inflammation to the whole ventricular cavity. And that leads to the adhesions at the aqueductal lesion. And that is when aqueductal stenosis happens. And suppose you have a meningitis related hydrocephalus, there because of the meninges gets involved, that is the leptomeningeal meningitis, they cause obstruction at the arachnoid villi and that lead to hydrocephalus. That would be a communicating hydrocephalus. So again, the cause of hydrocephalus also would determine what type of hydrocephalus we are dealing with.
Yeah. I think the congenital hydrocephalus, Nareshbhai, but can you just take the details that how we can differentiate Dandy-Walker or even the Porencephaly sometimes? So all the things, how we can differentiate and what can be the various reasons for this?
Clinically or
no, I think
imaging wise?
I think clinically and then radio imaging.
Yeah. So clinically, it is very difficult, sir. If the child is born with a large head, only thing that we see in Dandy-Walker is that the occipital region is slightly bulging. So if a pediatrician or neonatologist is quite careful in his observation, they'll be able to pick it up. Okay, sir. Imaging wise, for Dandy-Walker, there are 6 criteria. There is quite complicated, but I'll just run through that. So the Dandy-Walker hydrocephalus, the 6 criteria are that you have a large posterior fossa cyst that communicates with 4th ventricle. And since the 4th ventricle is communicated, that is why there is no vermis or cerebellar hypoplasia. And then there is a hydrocephalus. So these are the 3 main primary criteria. And then because the cyst is there antenatally during the developing brain, the posterior fossa volume is big. So you have a large posterior fossa. And the tentorium, trocula, that is what is the junction of superior sagittal sinus, inferior sagittal sinus, and straight sinus, and transverse sinus. That is quite moved away from the foramen of Monro, foramen of Magnum. So these are corollary, and the tentorium also becomes more horizontal. So these are the 6 criteria. So suppose you have these 6 criteria, then we call this as Dandy-Walker malformation. And suppose only one or two criteria are there, then we will call this as a Dandy Walker variant. Okay,
Right.
sir. So this is the most commonest congenital structural abnormality related to hydrocephalus.
Right.
Okay, sir. Sometimes we can see
At least
only.
for the sake of students, I just make it easy. What sir said, that basically clinically, if you see large head, and particularly this posterior part or occipitum is prominent, that may be the finding. And with you go for this radio imaging, what he said that basically malformation of posterior structures, particularly cerebellum and vermis, may be most common, and with that even the collection of fluid, and that is the variety of the Dandy Walker. I think similarly, Naresh bhai, Arnold-Chiari malformation is
Yes,
also,
sir.
I think, commonly the malformation. So how we will differentiate? And I think there are some types also according to the displacement.
No. That is totally different, sir. Actually, we'll not mix up that.
Right.
So ulnar carry malformation is an entity where the cerebral tonsil herniates below the foramen magnum level. Okay,
Right.
sir. So normally the cerebral tonsil should be within the cranium, should not come into the spinal canal. Okay. So what type of ulnar carry would cause hydrocephalus is only carry 2. Okay, sir. So carry 2 herniation is seen only in meningomyelocele.
Right.
Okay, sir. Carry 1 is an acquired condition. Carry 2 is a congenital condition that is pathognomonic for primary neurulation tube defects. Okay, so if a sonologist antenatally sees carry 2 herniation and hydrocephalus, it has to go with a primary neurulation tube defect of the spine. It cannot happen independently.
Right.
Then is herniation of cerebral tonsil along with occipital meningocele. Okay, sir. And carry 4 is that this whole thing is herniated and is open out, and they are not compatible with the survival. Okay, so carry herniation per se would not cause congenital hydrocephalus, except for carry 2. And again, carry 2 also, it is because of the meningomyelocele.
Right.
Okay. Now, the commonest thing that we see is that we see the dilated ventricle, the occipital horn, but the frontal horns are small, or fourth ventricle is small. Okay, sir. So now this entity is known as colpocephaly.
Right.
And this is again mislabeled as hydrocephalus, and a lot of children, they undergo treatment done also, but there is no surgical treatment required for them.
Right.
So from a student point of view, if the examiner asks, can there be a dilated occipital horn without dilatation of frontal horn, they can easily say that this is a colpocephaly. And that is a very benign entity, doesn't need any surgical or medical treatment.
Right.
And usually it is associated with corpus callosum agenesis. So in these children, they would have neurological retardation and all those stuff also in a long term. The rest thing that we discussed, congenital, was that you can have a dilated ventricle with a small head, sir.
Yeah.
So this is related to the torch group of infection. So torch serology. Torch serology would be positive for both the mother and the newborn. And this is because of the toxoplasmosis or CMV infection. They involve the brain, and then there is a cerebritis, and brain gets damaged, and then you have an ex vacuo dilatation of ventricle.
Yeah. So I think
so they don't resist.
Very important what Naresh bhai explained us, that ex vacuation hydrocephalus is different. Here there is no raised intracranial pressure, but ventricular system is dilated, and that is because the brain tissues are not growing. And most common in the torch, he said, cytomegalovirus and toxoplasmosis. And I think another thing, even you will get the intracranial calcifications in these two conditions.
Correct. Toxoplasmosis, even chorioretinitis happens,
Yeah.
sir. So even the ophthalmologist, if it is very good, he can pick it up also.
Yeah. And even the variety of the calcification intracranial also, cytomegalo, that is the periventricular, you may get this calcification. While in a case of toxoplasmosis, it will be the scattered calcification
all over the
brain, and that can also be the differentiating point radio imaging point of view, besides serological test and history and everything. So I think, and these are common even in our practice, if at all, if we get
Another
it.
interesting thing is
Yeah,
another interesting thing is, sir, that all this torch group of infection would have IUGR also.
yeah.
So when you have a dilated ventricle, small head circumference, small biparietal diameter, and IUGR, then it goes more towards the congenital infections.
I think here also what Janmijay mentioned, the birth weight was 1 point something. So extremely this, I would say, IUGR baby. Just simple, it was really anatomical acute stenosis or some other related reasons that also we should keep in mind. I think at the same time in achondroplasia, many times the examiners are asking that what is the reason for the hydrocephalus in a case of achondroplasia? Any student? Or I think Danish may will try to answer. Because you know, in you may get this in a radiology viva, there may be some X-rays, very classical pictures of achondroplasia, or even the patient of achondroplasia may be the short case or spot case. And in that case, there may be the hydrocephalus. And then why there is the hydrocephalus in a case of the achondroplasia? That means what type of mechanism or which factor is responsible?
You want me to answer, sir?
I think first students, otherwise then you
Actually, it's a googly. There is no hydrocephalus.
then I think I would like to listen from you.
Yes. It's a googly actually. Rarely achondroplasia presents with hydrocephalus.
Yeah.
Achondroplasia have dilated, they have macrocrania, meaning the head circumference is more than 95th percentile, but the ventricles are normal actually, sir. Okay, so that's a googly actually. Okay.
Actually, what explanation some people are offering, you know,
Yes, sir.
in the which type of the skeletal disorder is the achondroplasia? There are two types of the bone, membranous bone and cartilaginous bone. Here, the cartilaginous bones are affected in a case of achondroplasia. And having these cartilaginous bones, and that means the skull bones, base of the skull.
Correct.
Because the base of the skull is affected, it may obstruct the from the foramen magnum. What is the explanation? What the people
No. It is not the foramen
Not the
of
obstruction.
magnum.
Yeah.
But what happens is that the jugular foramen gets narrowed actually, sir.
Okay.
Where the internal jugular vein comes out of the brain actually, sir.
Okay. Then
So
it's
that-
contributing for developing hydrocephalus.
No, not really, sir, because they have measured the pressures and the intracranial pressures were never very high, sir.
Right.
So now we have come to an entity called normal pressure hydrocephalus also.
Yeah, that I think I was coming to that point because
Yeah.
it makes difference in the management and how.
Exactly.
I think can you take it before we go further? That
Yes. So achondroplasia,
normal tension,
usually,
I would say hydrocephalus, and how to decide and line of the treatment for that. Then we'll go to the shunt.
yeah, this is very rare actually, but as a student, they should know there are two conditions where they causes hydrocephalus. Achondroplasia causes macrocrania without dilatation of ventricles.
Right.
So you have an external hydrocephalus, meaning more CSF around the subarachnoid spaces outside the brain.
Brain tissues.
Yeah, outside the brain, inside the skull. Okay, so that doesn't need any surgical treatment from a hydrocephalus point of view because there is no hydrocephalus. Now there is another congenital disease that involves the bone that is called osteopetrosis.
Yeah.
Okay, again, the same thing happens. Osteopetrosis, the skull base foramen gets narrowed up. Okay, the jugular vein gets narrowed up. That builds up the pressure on the central venous system in the brain, and that leads to decreased absorption of CSF from the arachnoid villi. Because arachnoid villi, it would be on the gradient actually, sir. Okay, so here you have normal ventricles with high pressure. And the only way we can rule it out is that by doing a fundoscopic examination and you see a florid papilledema, and then they require a CSF diversion. So now osteopetrosis would have almost normal head, but severe raised ICT and normal ventricle. And actually, the skeletal X-ray, if somebody does the X-ray of the rib or the chest or the limbs, then it is diagnosed, that
Yeah,
ivory images actually.
but I
So
think
these are the two
I think,
conditions, skeletal condition that can lead to hydrocephalus needing interventions.
yeah. I think Naresh Bhai explained the 2 points very important for us, and something I will say new for me also. That in these 2 conditions, say chondroplasia and osteopetrosis, how it affects the CSF circulation or something, and what we consider hydrocephalus. He said that in true sense, it's not hydrocephalus, not dilated ventricular system. Even he said that hardly it requires the treatment. So it is very, very important, that surgical treatment particularly. So I think it's very important for us to note it. But he said that the ventricular system probably is not much affected, not dilated, or the pressure may not be increased. And so it is very, very important that we should consider normal pressure hydrocephalus, and which does not require the surgical intervention. I think similarly, Naresh bhai, can you take the point that post-meningitis hydrocephalus?
Correct.
Either it is bacterial meningitis or TBM.
Correct. TBM is a different entity. We'll discuss that also. But first, we'll come with the post-meningitis hydrocephalus that we come. Most commonest meningitis that we see is H. influenza, and that doesn't cause hydrocephalus. That causes subdural hygromas, and that resolves by itself. So that is not a big headache from a pediatrician point of view. Now, clinically, what we are worried is you have a bacterial meningitis like staph or E. coli, Pseudomonas, or any streptococcal meningitis. Because they attack, the inflammation is happening at the leptomeningeal level, leading to the malabsorption of CSF from the arachnoid villi, leading to a communicating hydrocephalus.
Yes.
So you have a child that is recovering from hydrocephalus, recovering from meningitis, completed the course of antibiotic, and then we see that the hydrocephalus happens. The head circumference starts increasing, and then the sun setting sign props up. So this is the
Sir explained
etiology.
very nicely that here it's a communicating variety, because I think the basic mechanisms all of us know for the hydrocephalus. Either there is a problem in the circulation, that is some obstruction, or there is some problem with the absorption, and that is with the subarachnoid villi or blunted or something like that, some mechanism. That can be post-hemorrhagic also or post-infective also. And third reason, even the excessive production, that may be in a case of ependymoma or something. So I
Correct
think
plexus papilloma.
Yeah. So I think these 3 mechanisms we can keep in mind. And here post-meningitis is said that there is no obstructive variety, communicating variety. And for that reason, proper treatment, I think, antibiotic point of view, is more important to prevent this problem or complications.
Correct.
I think now
antibiotic, and also a lot of people, they use steroid, during the active meningitis phase actually, to decrease the inflammatory part of it.
Right. Now, can you take it? I think suppose once you decide that what are the indications for surgical intervention, particularly the shunts, and we would like to learn from you that what type of the common shunts are present in the use, and I think related problems and cost and everything. This is very important for the pediatrician from practice point of view, and more so probably exam point of view for the students. So I think that you can focus.
Correct, sir. So now we come to our particular case. So this child was 2-month-old and had a diagnosis as recent hydrocephalus. So once the hydrocephalus is diagnosed, we are not coming to the discussion on the hydrocephalus now. You have dilated ventricle and you have raised ICT also. Okay, sir. So now we need to, before we put in a shunt, we need to have a CSF. Most commonest type that we do is that we do a lumbar CSF, hoping that the ventricular CSF and the lumbar CSF is communicating. Okay, sir. But abhi apna case mein hai, ya post ventriculitis hydrocephalus, we need to get a ventricular CSF instead of lumbar CSF. Or if there is an aqueductal stenosis, the lumbar CSF would not be representative of the ventricular CSF also, sir. So first we do the ventric CSF and make sure that there is no active infection and active infection, and the sugars are appropriate, not the single digit. If suppose there is an active infection, meaning more than 100 cells, and if it grows some organism, then we can't treat the hydrocephalus, meaning we can't put a foreign body shunt. But again, if the hydrocephalus is developing, the brain gets damaged, So we need to drain the CSF externally. So we call this as an external ventric reservoir, external ventric drainage, or we put a reservoir. Okay, sir. And once we complete the course of antibiotic and if the CSF is clear, then a VP shunt is inserted. So VP shunt meaning ventriculoperitoneal. Okay. Now coming to the ventricular.
I think that is the importance of CSF examination. Routine CSF examinations are wanted, and I think in any case, as he stated, that we should go for that, because it is quite useful. I think that is why, can you take particularly the meningitis, that is there any criteria from the CSF protein point of view for insertion of shunt?
Pardon, sir, I didn't get your last question, sir.
Particularly, I will, in a case of meningitis, I think more so in the tuberculous meningitis. That
so that I'll come to you.
Any criteria from the protein point of view?
Sir, actually, TB meningitis is totally different, and we'll discuss it slightly later. If you want to discuss right now, we'll discuss right away. The thing is that whatever TB meningitis that we see are the slightly grown-up children, more than 5 years, and we see the lumbar CSF that shows high protein content. And also high, means the cell count would be something like 2-digit, 60, 70 and all those stuff. Okay, and lymphocytic predominance. Now the myth is that not many people are aware of it, is that in tuberculous meningitis, there is a leptomeningitis that happens, and that leads to the high lumbar CSF. And when we put in a shunt, the shunt goes into the ventricular CSF, and ventricular CSF, unless there is a tuberculous ependymitis, that is very, very rare, the ventricular CSF is not having high protein. So the myth is that a lot of people, they do lumbar puncture and they think that, oh, protein is 350, protein is 500, and we should not be offering the shunt. In fact, when we do the CSF, the ventricle CSF proteins are very low, and the child can be safely offered VP shunt actually.
I think this is something we'll have to learn. Probably from many years we were taught in this way, that always the CSF protein is high, and it will get this, your shunt, if you put it, it is going to be blocked. And therefore, I will say even surgeons were also reluctant to put this.
No, not many neurosurgeons also know that, sir. In fact, I can challenge any of your students also, that last 5 TBM that they have seen, see the ventricular CSF, and after the shunt implantation, see the ventricular CSF, and you can see a craniospinal disassociation, sir.
Oh.
That is not been reported in the literature also, actually, sir.
Thank you very much, sir.
Sir, is it necessary then that if you're in the case of TB meningitis, we should go for a ventricular tapping as well as a spinal tapping to decide whether
No. Now again we are mixing up too many things. So we'll come to TB meningitis now. We'll go step by step. So when you when we have a child with TB meningitis, it affects brain by 3 ways. Okay, one is tuberculous meningitis, and leading to leptomeningitis and basal exudates. Second is vasculitis, that is because of the vasa vasorum getting inflammatory changes and vasculitis. And third is hydrocephalus. So now this hydrocephalus that happens, it happens gradually, number one, and that is reactive because the tuberculous meningitis inflammation causes blockage of the arachnoid villi. So almost all the TB meningitis have communicating hydrocephalus to start with. Okay, sir. Now, once we start giving AKT medicines, the inflammation decreases. If it is not MDRT TB, the tuberculosis also, the severity decreases, and the hydrocephalus would get opened up by itself. So it tides off the crisis. But the hydrocephalus causes so much of morbidity because of the decortication and decerebration and midbrain, it needs to be treated. So I have, as a neurosurgeon, I have a very low threshold. If I see there is a dilated ventricle and the temporal horns are increasing and PVL, the periventricular lucency is seen, immediately shunt has to be put. There is no discussion. Okay. Now we had a Udani classification long time, and that has been followed. Like what they say is stage 1 and stage 2, there is no hydrocephalus, so you don't put a shunt. and then stage 3 and stage 4 there is a gross moribund hydrocephalus, and then shunt surgery is not going to help. Again, these are two contradictory things. If the shunt surgery is done, the brain is protected, so brain gets adequate time for the AKT and steroids to act. That takes around 2 weeks to 3 weeks, and then everything gets resolved by itself. So now people are worried that if you put in a shunt, then there would be shunt malfunction, obstruction, and all those stuff. And they keep on giving fancy reasons that the proteins are high and all those stuff. It's the other way around. The moment you treat the hydrocephalus, the raised intracranial pressure is taken care. The child becomes less morbid and moribund. And we need to give some time for AKT and steroids to act actually.
Okay. So I think
Thank you.
this is very important and new even from a practice point of view to learn. Definitely, particularly now with the reference to tuberculous meningitis.
Yes, tuberculous meningitis. I have a very low threshold to put a shunt because we don't want to lose a child.
Right. Anything, Dr. Deepa, from your side?
It's very clear cut message that he has given,
Yeah,
because
yeah.
many times even we do have a problem that our neurosurgeons, they're still
Absolutely.
reluctant to put on a shunt if the proteins are high.
No, but tell them, do a ventric tap and see, what is the CSF, then
Right.
they'll get the answer actually. Sir.
Yes. Yes, sir, definitely.
Now the next question, Dr. Naresh Bhai, I'm sure that we'll take the maximum benefits from your expertise. Once you decide to go for the shunt, then which are the various available shunts and which is commonly you are doing, pros and cons of everything, and even its problem and complication. I'm sure that for general pediatrician, very important for us to know.
Yeah. So now we come to the shunt, the rule of thumb is very simple, sir. If the frontal L is open, it's a low pressure shunt. If the frontal L is closed, it's a medium pressure shunt. High pressure shunt is only used in certain conditions like pseudotumor cerebral. Okay. Now the googly here is that you have a tuberculous meningitis hydrocephalus. They always need a low pressure shunt. The hydrocephalus, there is a low pressure compartmental hydrocephalus. So the rule of thumb is again open frontal L, low pressure shunt, no discussion. Medium pressure shunt for all the hydrocephalus that after AF is closed. And for tuberculous meningitis, irrespective of age, it is always low pressure shunt.
Right.
Okay. Now, how do we decide about the pressure? It is the opening pressure of the CSF that is measured. So low pressure would be less than 4 centimeters of water. Medium pressure would be up to 8 centimeters of water. And high pressure would be up to 12 centimeters of water. Okay. Regarding the types of shunt, in world, we have almost like, you wanted to say.
Sorry to interrupt you, but for the sake of student, this may be routine for you, but for us to remember.
Yes, sir.
What he said that for the low pressure, less than 4 centimeter water. For the medium pressure, I think if I'm doing the mistake, Dr. Naresh, please correct me. That 4 to 8 millimeter, he said that is medium pressure. And more than 12, he said that is high pressure shunt. Am I right?
Yes, sir. Absolutely.
I think very important for us to remember, and very clearly he said that what are the indications for the low pressure, medium pressure, and high pressure shunts. Very clearly he made. I'm sure that this is quite useful. Please take it further.
Yes, sir.
We may interrupt you. For
Feel free, sir. No problem at all. So now the shunt, when we talk about shunt, there are in market, sir, there are 100 varieties of shunt.
Oh.
Okay, sir. In world, all over the world, there are more than 100 varieties of shunt. What does that mean? It just means that there is no perfection.
Right.
Okay. So now whatever is available to us in India is Chabra shunt, that is quite cheap. Okay. And in fact, now the European countries and Africa countries are importing our shunts actually. Sir.
Oh.
Yes. It's very good shunt. And the best part of the Chabra shunt is that it works good even in high protein environment.
Right.
Okay. From the student's point of view, if the examiner asks what type of shunts you have heard, you can tell that you are Chabra shunt. Then if somebody wants to know, is there any special shunts that is available, then there is something called programmable shunts. So there are specific reasons why we put a programmable shunt. And the beauty of programmable shunt is that they are magnetic shunts where the pressure can be changed externally. One is either mechanically or by electricity. And now, again, because of the shunt infection and problems, what we are seeing, another thing that we have started seeing is the antibiotic coated shunts. Okay. The shunt hardware is coated with rifampicin and clindamycin. It's a patented technology from abroad. So when it comes to India, it is expensive. But yes, these are the three things from a student. If somebody asks them a question in the examiner, if some means I'll put it the other way around. If the examiner is coming till the types of shunt, probably has got a distinction.
But I think even students are knowing, and if you convey this information, examiner will appreciate that, okay, I was not knowing something good, I will say information from the students. So definitely, as he said, the different types of Chabra shunt is most commonly accepted. Another variety, at least what he said, that is a programmable shunt. And third, even he said that even antibiotic covered shunts are also available. So I'm sure that this is quite useful to us. Thank you. Please go ahead.
Yeah. So now we have implanted the shunt now. So the first thing that people are worried is what is the complications that we can encounter, after the shunt surgery. So there are two types of complications. One is mechanical and second is infective. Okay. So we'll first come to the mechanical. Mechanical can be malfunction. That is a proximal malfunction of the wall, or malfunction of the in the abdomen, the distal malfunction. And there can be a failure, structural failure or breakage of the shunt that can happen. So these are the four types of mechanical complications that we can expect. And the more dreaded complication is the infection. Okay. Since we are implanting a foreign body, before the skin flora attacks the foreign body, it has to be done appropriately. Okay. So shunt infection is most commonly seen in first 4 weeks of implantation. Almost like 75% of shunt infection happens within first 4 weeks of shunt implantation. And in 1 month to 6 month duration, remaining 20% happens. So almost like in first 6 months after shunt surgery implantation, 95% of the shunt infection would have happened. After that is very, very rare. So suppose you get a child that had a shunt surgery done last year and comes with fever. So shunt infection should be the last in the priority list of the pediatrician.
Right.
And suppose the child comes with fever in, say, a week after shunt surgery, न्यूरोसर्जन क्या करता है, धकल देता है, अरे नहीं शंट का प्रॉब्लम नहीं है, का प्रॉब्लम देखो, यूआरटीआई, एलआरटीआई, यूटीआई देखिए. But it's the other way around. Pediatrician should be firm and tell that since shunt has been implanted a week back, you first rule out that there is no shunt infection.
Right.
Okay.
I think very important point.
Yes. So now the shunt infection that happens are again two varieties actually, sir. So one is a meningitis, that is a CSF infection, and second is a infection around the shunt layer, that is we call as a slimy layer. Okay, that happens because of the staph aureus and albus. They form a biofilm, and that is why no antibiotic treatment is going to suffice also. So suppose a child develops a shunt infection and has a biofilm, unless the shunt implanted shunt is removed, the infection doesn't get cured, number one. And another important thing is that once a child develops a fever, suspected shunt infection, no matter how many lumbar puncture or CSF examination we do, the CSF would come normal actually. So shunt infection is more of a clinical thing. A normal child after shunt implantation should not develop fever or a persistent fever or CRP raising, the total counts raising, the erythema around the shunt surgery or a swelling around the shunt surgery, shunt tract, is all signs and symptoms of shunt infection.
Another point that suppose, after the shunt, child is coming for the follow-up to the pediatrician. So I think infection point of view explained very nicely that regarding the timing and chances of infection, at what time, even type of infection, that biofilm and the meningitis. But how to monitor that this particular shunt is functioning properly?
Exactly. So there is a big myth actually, that what happens is when the shunt is implanted, the pediatrician tell the family, that keep on pressing the wall, okay, and keep on checking that, So the example that I give to the family or pediatrician is that, suppose we buy a car, do we push it every day to start it, or it starts with ignition? The same thing happens with the shunt also. When we are putting a shunt, the shunts are tested in vivo and in vitro, means outside and inside. The opening pressure, it's a simple physics and hydrostatic pressure. So they don't need to be checked or pumped actually.
Right.
In fact, by pumping, probably we are trying to damage the spring valve mechanism and can cause malfunction. Okay. So suppose a child has been shunted, the easiest way to monitor is the AF, anterior frontal relay and head circumference.
Right.
And after 3 months, what I do is I do a baseline imaging. So 3 months is enough time for us to know, clinician to know how much the brain has recovered back from the hydrocephalus. And that first 3 month imaging becomes the new baseline imaging, against which further time we can compare the things.
Right. So I think, as you said, there is no need to press over the chamber at the mastoid cell also. Which we
Correct.
were
Absolutely. It's a contraindicated.
Yeah. So on the contrary, he said contraindication. He said very important point that this monitoring is clinical signs, anterior frontal relay, head circumference, and if at all, he said radio imaging. Very important point that how we should monitor. But I think what in the past we were taught that to press over the chamber and to see, I think as he said, on the contrary, we may damage it. So very
Correct.
important message, I think, for all of us.
Yes, and the best thing that I find is that, so what happens, sir, in Bombay at least, people, the family keeps on changing the pediatricians actually. तो एक pediatrician के पास, अरे वो तो तुम्हारे को पंप करना नहीं सिखाया है, ये तो गलती हो गया ऐसा वैसा. So the best thing that I do is I tell the family the reason and the logic also. So tomorrow when the family goes to a pediatrician, different pediatrician, and the pediatrician asks, why you are not pumping the shunt? So they say, no, नहीं हमको डॉक्टर बियानी ने बोला है कि पंप करने से खराब हो जाएगा तो हम नहीं कर रहे.
Right.
So like better to take family in confidence and give them the reason why you have told them that.
Right. I think very important. Any question from the students before we end?
Very informative, sir. Thank you so much. I learned a lot. So I have discussed hydrocephalus many times, but
So,
your viewpoint, of course, differs from many other people who are, as you have mentioned.
Actually,
So,
sir, I am
yeah.
a pediatric neurosurgeon and practicing for past 20 years.
Yeah.
And I've been like breaking my head with all the pediatricians trying to explain these things.
No, it's very important that you had come in and given so much of valuable information.
No,
Thank
no.
you.
Prajapati sir knows me very well, and whenever there is something, he makes sure that I am involved in that.
Yeah, that's why I was coming to that point, Dr. Naresh Bhai, that we are troubling you for knowing all these things and for more clarity. And every time, probably we get more and more clear points. So definitely,
So,
I
one
think
more
Dr. Deepa
question
has
for
some
me.
question.
Yeah. Sir, whenever a child presents with a meningomyelocele and a hydrocephalus, so my question
Correct.
to Biyani sir, what is the preferred, which is the first one to be operated? Because there appears to be some controversy regarding which operative
No,
procedure.
there is no, actually, absolutely, there is no controversy, ma'am. So now there are 3-4 ways that the child can present. Okay. The most commonest thing that we see is the antenatally diagnosed meningomyelocele and presented with ruptured meningomyelocele and got infected.
Yes.
Okay. The child didn't had an hydrocephalus. So here it is straightforward. We operate meningomyelocele. If and when the hydrocephalus develop, we take care of it.
Okay.
Okay.
Yes.
Now, second situation comes is that antenatally the child had a large head, so has a hydrocephalus and meningomyelocele.
Yes.
Okay. But it is not ruptured. So if it is not ruptured, that's very rare. That happens only when the child is delivered in institution and enough care has been taken. So what I would do is I'll shunt the baby and also in the same anesthesia repair the meningomyelocele.
Okay.
Okay. The most commonest thing that we see now is that you have a hydrocephalus with ruptured meningomyelocele. Okay, and that has got infected also.
Hmm.
So in that scenario, what we do is that we put a reservoir. So we take care of the hydrocephalus and we repair the meningomyelocele,
Yes.
give enough antibiotics.
Hmm.
We keep on tapping the reservoir
Okay.
and checking the CSF. If the CSF is not infected, then a shunt can be implanted.
Okay. Okay. That.
And suppose by just putting the reservoir and after closure of meningomyelocele and after control of infection, certain children, they don't develop hydrocephalus also.
Hmm.
So after 3 months, even the reservoir can be removed.
Okay. Okay. Thank you so much.
So it's a simple flow
Yes, sir.
chart.
So you are
Actually. There is no
you are
confusion.
giving such a clear-cut message, but many times we get it like many controversial opinions regarding this.
नहीं वो होता है मैम. देखिए क्या है, अभी मेनिंगोमाइलोसिल हाइड्रोसेफलस पीडियाट्रिक सर्जन भी ऑपरेट करते हैं, न्यूरो सर्जन भी ऑपरेट.
Yes, yes.
अभी न्यूरो सर्जन को बच्चे को ऑपरेट नहीं करना है तो पीडियाट्रिक सर्जन के गले पे डाल दो. और more problem that I find is that they give such a bad prognosis that even family and pediatrician, they say why to get treated also. You know? Just don't treat the baby also. You know, let the baby die. It's something like that. You know, so it's a lot of ethical and moral dilemma that surgeon faces. Actually.
Yes.
Can I ask a doubt, sir?
Sir, sir.
Yes, sir. Yes, sir.
It may sound a bit silly, but I think I want to have clarification. Usually, you know, from the tension point of view, it is divided as normotensive, hypertensive, hydrocephalus. So usually adults, of course, with the degenerating brain, they have hypotensive hydrocephalus. What is this distribution in childhood hydrocephalus? Any?
No, childhood, we don't see that, sir.
Yeah.
The adulthood, late onset, normal pressure hydrocephalus or low pressure hydrocephalus is because of the cortical atrophy that happens.
Yeah, that's true. Yeah.
So have a dilated ventricle. They present with the triad of dementia, incontinence, and motor dysfunction, the dyspraxia.
Yeah.
And we do a lumbar puncture. And if the incontinence and dyspraxia improves, you know, then they are the candidate for the CSF diversion. That's a totally separate entity that we hardly see in children actually.
So because I haven't heard of hypotensive in children, that's why I want to make clear.
No. Hypotensive is unheard. The only thing that we see commonly is that in tuberculous meningitis, you have hydrocephalus and people have put a medium pressure shunt and still the babies have not woken up, you know. So there is a low pressure hydrocephalus and they require low pressure system.
Right.
Thank you, sir.
I think Dr. Naresh, you were talking regarding the reservoir. That is, we have heard this Omaya reservoir. What is it?
Omaya and reservoir are the same, sir.
Yeah, the same one you are using.
Omaya is actually Johnson & Johnson. It's very expensive. And what we are using is a Surgiware company, the Chabra shunt that they make, you know, they have come with their own reservoir, cerebral reservoir. And that's quite cheap in India. But they are the same.
The Upadhyaya shunt was there by Holiday Institute long back.
Correct.
Upadhyaya shunt, that was India.
Yeah. That they were the pioneers actually.
Yeah.
Then and a lot of lives have been saved.
Yeah.
But now after 1988, Chabra shunt has become popular.
Yeah.
And that is the most modern shunt that we are having right now.
Dr. Naresh, can you take that? What are the specific indications for using this reservoir?
Reservoir, it's very easy actually, sir. So why do we put a reservoir? You know?
Yeah.
Yes.
So you have hydrocephalus and you can't shut the baby. It's as simple as that.
Yeah.
Yes.
So you want to protect the brain from raised ICT. And the CSF is infected or the baby is very small to get the shunt implanted. Yeah, it's as simple as that. You know, the moment you understand these two indications, we can only make out the indication, you know, prematurity, infection, all those stuff. You know.
So I think now it's a time for us to end. But before we end, any question to Dr. Naresh? And I'm sure that at some other time like this discussion is there, we'll bother you. Because,
yes. I'm more than happy to help our junior colleagues.
Because all these students definitely, and what we wish that from the beginning, suppose if they have the clear concepts and this even the modern information, current information, that will help you not only the exam, but in the practice also. So any question or we land over here? Anyway, Chanmeche, thank you very much. I think our selection of case was good. so that we could raise all these issues and we could learn definitely. And of course, Dr. Naresh bhai, definitely you made so many, I would say, concepts clear to us, not only to the students, but I'm sure that to even us, to the practicing and even the senior faculties. And of
Wish you all
course,
happy Dasara festival in Gujarat. It's so famous. Enjoy. Thank you.
and presence of Dr. Srinivasan sir and Dr. Deepa also makes a difference in our learning. Their points, comments. Thank you very much to both of them and to all the students. I think at least the students now remaining present in the large number. That gradually I repeat that you should be vocal, raise the question, try to respond, and I will say, that is the best methodology of learning, interactive rather than just passive listening. I'm sure that all of you will do in the due course of time. So we end over here. Thank you very much to all of you. And I should
Good night,
thank
all of
even
you.
this,
Have a nice
Shweta,
weekend.
Iap
Thank you, sir.
person, and our President and Secretary for providing this platform. Thank you very much again,
Thank
Dr.
you.
Naresh bhai, and to all the faculties and all the students.
Yes, sir. Thank you, sir. My pleasure.
Thank you, sir. Thank you, sir.